So my name is Carrie Morris. I am a licensed marriage and family therapist, and I am also a certified sex therapist. And today we are going to talk about anatomy, orgasms, and when things go awry. I'm going to be sharing my screen, so I'm not going to be able to see the chat. But if you have any questions, put them there, and if I have time at the end of the 30 minutes, I can come back and check. And we'll get started. All right, so body talk, anatomy, orgasms, and sexual mishaps. I am a complete science nerd. I love the human body. I love talking about these things and finding all these fun facts about the body, and also, like helping people through when things don't go as planned. And so that's what we're going to really get into this evening. Okay, so let's start off with the vulva. So here you have a diagram of the vulva, and I say vulva, that's generally what the whole genital area of a female is called. And, here we say vagina a lot of the time. That's okay. Vagina is generally just the vaginal opening, and the vaginal muscles inside. And so I always refer to it as the vulva. And so here you can see all of the different parts of the vulva. You have your urethra there. You have the clitoris, which we're going to be talking about this evening. You have the labia minora, which is the inner lips, and then the labia majora, which are the outer lips. Something I always want to talk about here is when you see, graphs like these or images like these, not every vulva looks that way. I think that there is definitely a cultural kind of perfect pussy in our culture, and that's just not true. Sometimes the clitoris is moved over to the right a little bit. Sometimes the urethra and the clitoris are a lot closer together. And so, if you or your partners or someone is like, oh, mine really doesn't look like it looks like in porn, that's completely normal. And so one of the things that I really wanted to talk about here is squirting. So that is probably one of the biggest questions I get as a sex therapist. And it is a topic that is so contested, even in the science community. Like, I read one scientific study and it says one thing and the next says says something different, excuse me. And so we're just going to kind of go through what I know about it now and kind of what the new science talks about. And so in a 2023 study, they found that 41% of women have experienced squirting in their lifetime, whether they wanted to or not. Some people chase it, some people find it embarrassing. It just really kind of depends on the person. And if you'll look at this model, you're going to see right beside the clitoris are these two little glands called the Skene's glands. And those Skene's glands produce a white, milky substance that is very similar to ejaculate in a man. And so this is really responsible for female ejaculation. A fun fact about that is the Skene's gland, the liquid that it produces, or the ejaculate it produces, is so close to men's ejaculate that it actually is there to help the sperm kind of acclimate to that environment, so it can, go and fertilize an egg. And so when you have squirting, which is a bigger release of fluid, most of the time that contains fluid from the bladder. Sometimes it's clear and odorless, which kind of sets it apart from urine. Sometimes it is urine. But at the end of the day, like, if squirting is fun and consensual and it brings you and your partner's joy, like, who cares what it is? A lot of women do love squirting. And so one of the studies that kind of figured this out happened in 2022, where they actually kind of gave a woman like dye. And so the dye would be in the bladder, and it was a woman who could, just squirt most of the time when she orgasmed, or sometimes squirting happens without orgasm, but a lot of the fluid that was seen after the squirt was the same color as the dye. So that's one of the reasons that they figured this out. But there's been very little study on it. A lot of women don't talk about it, especially in scientific communities. And so I just wanted to talk about that. And again, you can probably speak to me 3 years from now, and I'm going to have a completely different scientific story to tell you. So hopefully there's going to be some more research. Another thing that I wanted to talk about is another contested thing, which is the G-spot. You know, scientific community are saying all sorts of stuff, that it's just the backside of the clitoris, that it doesn't exist at all, which, you know, I think is laudable. But it is there, and it's generally located 2 to 3 inches up. Oop, I got a topper there, up the front of the vaginal wall. And so it's named after Grafenberg, who was the scientist way back in the day who kind of found this tissue in the vagina. And then there was a woman, her name is Beverly Whipple. She's a complete badass. She's a sex researcher. And when she was kind of searching for different pleasure spots for women who had illness or cancer, she found this Grafenberg spot and kind of brought it back out into modern day lexicon. And for a while, people were actually going to call the G spot the Whipple tickle, which I think is great. And I think that I should probably start calling it from here on out. But at the end of the day, when she wrote all of her research, she decided to, you know, give Grafenberg some you know, props for finding this. And so she named it the G spot. Really, what the G spot would probably be more likely is more of a G zone, right? And so there's a lot of things going up in that area of the vagina, and you could have the backside of the clitoris. You could also have the, you know, you're hitting up against the urethral tissues. And then, you know, it could be just some other types of pleasurable tissues in that area. A lot of researchers have talked about that there is more stimulation there after an orgasm, or when there is a lot of arousal present. And of course, sometimes people have talked about how stimulating the G-spot is connected to squirting. So those are some things that come up. So let's move on to the clitoris. One of my favorite things to talk about is the clitoris, because I think that, you know, I'm talking to some pretty, you know, like some pretty sex positive folks here, but I am always really surprised that some people don't know a lot about the clitoris, or they think that the clitoris is just the teeny tiny little clitoris glands here at the top of the vaginal opening. But actually the clitoris is, as you see here, is kind of this downward V. It is a large organ in your vulva, and that whole area is very pleasurable. And so the clitoris is the sensation station of the vulva. It is really, really densely packed with 8,000 nerve endings. That's twice as many as the penis. So, you know, like vulvas have got it going on in that situation. And one thing about the clitoris too, and even with orgasms, are they're immortal, right? The clitoris never ages. Just like the penis, you know, like penile function and clitoral function is good for your lifetime. So that is also something to understand. So the average length of time to orgasm for a woman is 13.5 minutes. And for men, it's 5 to 7 minutes. These are just average numbers. I generally don't like to pay a ton of attention to these numbers because everyone is different, right? Some other things about the female orgasm too that I find really interesting is there's new studies coming out, and they have found that a woman's pain threshold increases by 75% during an orgasm. And then their pain, like the way that they feel pain or they detect pain, it raises 107% during orgasm. So, there's been a lot of studies with, like orgasms effect on migraines. There's been a lot of success with folks, females having orgasms that help the migraines, because there is such a rush of hormones. There's such a rush of, oxytocin, and those pleasure hormones that come out that really do have some pain fighting properties there. So let's go to the male reproductive anatomy. And so when we look at the testes and the scrotum, one thing to remember about the scrotum is its job is to keep the testes really comfy and warm. So I don't know if any of you remember the Seinfeld episode where, George is like, I was in the pool, because, he had a lot of shrinkage. And that's really, really true. When it's cold outside, the scrotum will scrunch up and hold the testes closer to the body so it can be a little bit warmer. And then, of course, on hot days, they can just, they can hang all out where they want to be. And so in the testes, that is what produces sperm and testosterone. So with the penis as well, if you look at this graph, the penis is actually a lot larger than you think it is, or you can claim. And so the penis goes all the way internally into the body. And the whole myth about shoe size is not true. There's been studies on that, and there's no correlation between shoe size and a myth. So, it's really hard to tell a penis size from the outside. And one really cool thing I think that they've seen in studies is the penis size has increased in the last 30 years. So, those organs are just getting bigger and bigger. And the average now is 5.4 inches. Again, that is just an average, and that's a very medium number, and all penis sizes are perfectly normal and perfect just the way they are. One fun fact is the Americas have the biggest penises in the world. So, Latin America, North America, and Canada. And so another thing to talk about here is like the angle of the dangle doesn't matter. Like some penises kind of push up, some kind of angle down, some to the left or the right. So however your penis looks, again, it's perfect. So just like with the vulvas, just like with all genitals, there's a whole world out there of how they look and how they respond. And so growers versus showers is also a true thing. And so whatever you're working with is just right. Another fun fact about penises is generally in the REM cycle of sleep, you have about 3 to 5 erections during that time. And that is your body working out that penis for you. So you need to continually kind of have erections with blood flow. It keeps that organ really healthy. And so the body just sometimes does that on its own during sleep. So I think I wrote a little story for y'all about the semen journey, because I think this is a really cool thing to know and to talk about. And so you have the baby sperm, and they get big and strong in the epididymis, which is this little like tubes, like circular tubes above the testes. And then they take the swim of the vas deferens. And when they get into the seminal vesicle there, they pick up fructose, which is what they use to survive. So they pick up a little snack. And then they also pick up a fluid that becomes part of the ejaculate. And its job is to help mellow out the vaginal pH. So it wants to make sure that when, all those little sperms get deposited into a vagina, that it's a nice mellow space for them to live. And so then it kind of goes down and it's like, hey, we're coming. And so it gets to the prostate, and that prostate gland cuts off the urine, and it also gives it more juice. So that's where the vast majority of the ejaculate fluid is going to come out. And then the last stop is the Cowper's gland. And what that does is it releases fluid that will it will kind of mellow out the urethral tube. And so if there's any leftover urine in there, it's going to neutralize that. And so the sperm can have a safe trip out. And sperm and ejaculate can travel up to 28 miles an hour when it comes out of the head of the penis. I mean, that is just like, whew. I mean, think about driving 28 miles an hour next time you're in your car. And that's how fast you could possibly come. So when it comes to prostate pleasure, I get, of course, a lot of questions on this. And so here is a little diagram. Of course, it's a medical diagram, so they have on gloves. You know, we could maybe talk about some medical role play like we talked about last month. But when it comes to the prostate, people refer to this as the male G-spot. And, you know, a lot of people who have really good success with prostate pleasure, they call them super orgasms. And so how they describe them are kind of more full body orgasms. They're more internal feeling. Some men report that they can have multiple orgasms through the prostate. And some men report that they are dry orgasms. So there's no ejaculation during these, but they are these full body orgasms. And so how you can get to the prostate is internal or external. So just like on the diagram here, you can, you know, either use your finger, your partner can use their finger. There's a lot of prostate toys on the market. And so you go 1 to 2 inches in on the frontal wall. So it's like the frontal wall of the anus. And so a lot of people do the come hither approach. So it's kind of like this. If you're looking for the G-spot in a woman, you're going to turn it around and do this, like the come hither approach. And you can find that little kind of that piece of tissue there. And so you can also reach the prostate through external massage, which is the perineum massage. So this is right between the scrotum and the anus. And so you can massage that area. And the kind of tip to use is if it kind of makes you feel like you have to pee, more than likely you are on the right spot. And so you kind of know you're right there. And so a couple little things about ejaculation too. So orgasms are from partner sex are snoozier than masturbation. And so when you have partnered sex, your body produces more prolactin, which is kind of responsible for feelings of contentment and relaxation. And when you masturbate, prolactin is not as prevalent after sex. And so that's why when you're you know, with your partner and you have sex, you're just like, oh, I must take a nap. This is generally also can be linked to the refractory period, which is the period in between orgasm and being able to get an erection again. And so generally the refractory period is a little longer with partnered sex rather than masturbation. And with the refractory period, it can be improved with use. So the more you're able to, you know, orgasm, sometimes the lower the refractory period can get, leading to a phrase of use it or snooze it. Another thing I wanted to mention too is there's a big myth that pre-cum doesn't have sperm, or, you know, that is a type of birth control. There's a joke in the sex therapy world, and of course you can use it too, is what do you call what do you call people, I'll just ruin it. What do you call people who use the pull-out technique? Parents, right? So just definitely remember that, you know, you can get pregnant from pre-cum. So next I'm going to talk about penile disappointment. I made these slides just a little bit more robust so you can come back and use them for reference. And so when it comes to erectile dysfunction, I generally don't like to use that word. I like to say penile disappointment or vulvular disappointment because there's nothing wrong with you. You know, 43% of men report some ED in their lifetime. And so this can be for all sorts of reasons. It could be biological reasons such as low testosterone, illness. Certain medications like SSRIs really inhibit erection and orgasm for all genders. And then also substance use. You know, a little bit of alcohol a lot of times can enhance sex, but a lot of alcohol usually really dampens down arousal and erection. We all know what whiskey dick is, right? So other things that can really affect erection are anxiety, stress, overstimulation in the environment, depression. And I always encourage people to be really careful with internet information. You know, like you're going to get a lot of people trying to sell you things, you know, vitamins and different sorts of, you know, like drugs. You go to the gas station and you're going to see like tiger's blood, hard pills, you know, or whatever they sell. And so, you know, if you are having a problem with this, if it's happening over 50% of the time, definitely reach out to a doctor. Men have a lot of options out there for penile disappointment. They have a lot more than women do. And so when it comes to erectile dysfunction, the inability to get hard, always assess for your level of anxiety. You know, you don't want this to become this feedback loop where, you know, you're unable to get an erection, and then the next time you have sex, you're scared that it's going to happen again, and that anxiety about it possibly happening again can definitely increase that anxiety, and so you can't get an erection. So it really snowballs, and it can become an issue. And so definitely breathe when it happens. You know, this is absolutely normal. Look for lifestyle tweaks. You know, definitely exercise helps. You get that blood flow. Smoking and, of course, alcohol can affect this. And with that mindfulness, don't chase erections. You know, like when you're chasing erections and you're really focused on getting one, a lot of times that's where problems can arise. And when it comes to practical applications, there's cock rings that will hold the blood in the penis. You have penis pumps that will, you know, like let the blood flow come into the penis. And then some position changes. So if you're having some erectile dysfunction, maybe you have a chubby and not a full erection, there are different positions that you can use where you may not have to have a full erection to do that. So definitely like spooning, you know, when the male is behind the female, you can kind of, you know, do some grinding there. And so then you have premature ejaculation. And that's where a lot of mindfulness comes in. You're going to want to slow it way down. You know, you're going to want to see where that excitement is coming from, where that kind of anxious energy is sometimes for people who have premature ejaculation. And there's a little bit more practical application approaches here. The start-stop method, which is edging with intention. You know, so when you kind of get close to that orgasm, you're going to back off a little bit. You're going to, you know, kind of do some breathing, and then you're going to go back into it. And then you do that about 3 or 4 times before you allow yourself to orgasm. Then you have the squeeze technique, which is, you know, when you are starting to feel like you're close to orgasming, you're going to take the right underneath the head of the penis. So you can do this, or your partner can, and you can constrict just below the head, and that will stop the orgasm from happening. And again, you can breathe. Take a few moments. And then you can also use like reps, like you're working out. And so, you know, if you're premature ejaculation, you know, like, well, I know I can get like 3 or 4 pumps in before I come. Let's do, all right, 1, 2, 3, 4, and then let's see if we can add a 5th and keep doing that. And that, of course, involves some partner work. And, you know, it doesn't have to be super serious, you know, maybe even find some joy with that, you know, celebrate it if you get a couple extra reps in. And so then you have delayed ejaculation, again, with the mindfulness. I'm a therapist. I'm going to talk about that all day long. With delayed ejaculation, a lot of times it's watching the clock. Man, I'm taking so long. What is my partner doing? Are they getting bored? Do they want this to stop? And so being more embodied in that moment can really help. And then switching up the script. So a lot of people that have delayed ejaculation need more stimulation than maybe other people do. So do you need some like firmer touches, maybe some firmer like hand jobs, some different types of sex toys so you get more stimulation on the penis? And then challenge the social norms of orgasm. You know, there's a lot of fun that can be had without that getting from point A to point B. And so if you find yourself really focusing on that orgasm, you could possibly be missing a lot of fun along the way. So let's go into the vulva disappointment for women. And so again, 30 to 50% of women report some disappointment in their lifetime. And so there could be the same biological reasons, you know, hormone changes, menstrual cycle, different medications, anxiety, stress, overstimulation, and depression, again, for women. And so with women, generally we kind of think of women as being a little bit more complicated. So a lot of times we look at, is it desire that we have a problem with? Is it like physiological arousal? Or is it orgasm disappointment? And so that's how we kind of look at what exactly is going on. And so when you have low desire, it's just like some women just are not thinking about it very much, or they have a problem with, you know, like kind of wanting to do it or having that desire to have sex. And so learning about your accelerators and your brakes. And so your accelerators are what turns you on, you know, and that can be anything. It could be like, you know, watching The Witcher, or it can be your partner doing dishes. You know, it can be whatever it is that, you know, like gets you going. And then with breaks, there's two types of breaks. There's immediate breaks, and these are things that just cut off arousal or a desire. So this is like grandma walking in on you, you know, like masturbating. Or there can be these more insidious breaks, and those are these things like anxiety or maybe sexual myths. And so a lot of times with low desire, I start again with mindfulness and trying to clear that mind clutter. You know, like, are you spending time, you know, with yourself? Are you giving yourself space to think about sex? Or is your brain just going everywhere during the day and you don't even know where to turn and you don't even have time to think about it? And so then we're moving into the arousal disappointment. And so there's a difference between spontaneous versus responsive arousal. Spontaneous arousal is, again, you're just kind of watching television and bam, there it is. Responsive arousal, a lot of times is possible when it's like, you know, I'm not really aroused at the moment, but I think let's try, you know, let's see if I can get there. And with that responsive arousal, always consent is the measure. So there's always a caveat of like, well, if my arousal doesn't come, you know, I can stop, you know, this train when I want to. And so with arousal, a lot of times with mindfulness, I do a lot of sensual self-care. And so, you know, that's really getting embodied in your senses, taking a sensual shower, you know, smelling your soap. How do the bubbles feel? What do they, you know, sound like when they're popping? What do things feel like on your skin? Because when you're in the shower, you're not doing anything else anyway. Usually when I ask clients what they're thinking about in the shower, it's what to do at work, or my brain's pretty empty. So you're in there anyway. So this is a great time to do some sensual self-care. And watch for fear traps. You know, like this fear trap, it's kind of like the negative feedback loop with men. You know, like, oh, I'm not going to get aroused tonight. I haven't been aroused the last 3 times. So, you know, I'm just not even going to try anymore. And we kind of see that negative feedback loop a lot with clients. And then there's pleasure versus performance. You know, and I think this is kind of a double-edged sword too, because a lot of people love to perform for their partners. You know, they want to, you know, be desired, but then some people feel like they need to. And so especially when there is some arousal disappointment, I always want to make sure the female is, you know, going from her state, you know, her own pleasure, instead of, you know, working it out for the partner. And then last but not least is orgasm troubles. And so with mindfulness, breathing is very important for orgasm. Orgasm has to take place in a space where people feel safe, because orgasm is when you are completely out of control. And so when you are in a space where you're safe, you're able to breathe. When you're in a place where you're fearful or you're not safe, your body tenses up, you're not able to breathe, or you're shallow breathing. So just being in that, having that ability to breathe deep is going to send a message to your body that you're in a safe space and it's okay to lose control. A lot of women really love fantasy, love erotica. Orgasm is a lot more than mechanical for some people. This is not just women, it's for men too. So exploring fantasy work. One of my favorite things to do with clients, here in Greenville, we have Mr. K's used bookstore. I'm sure there's used bookstores where you live, and they have a huge erotica section where you have any type of erotica you can think of there. And so I send, women out just to try to normalize it. Like, hey, look at these hundreds of thousands of books sometimes. All of them are, erotica, and you can really find what you like. And then again, sensual self-care too for orgasm. A lot of times sensual self-care with orgasm trouble is masturbation exploration. So, like especially if you're working with a sex therapist like me, there's directed masturbation. So we kind of create a plan for you to go home, kind of work through what turns you on, what is leading you to orgasm through masturbation. And then you're able to take that knowledge and go to your partner and say like, hey, my body's changed a little bit. This is something that I learned about myself. Maybe I need to use a vibrator now. Maybe I need a little bit of different stimulation, whatever you need that you can integrate with your partners and that new information. I'm going to stop sharing here and go back to the chat just to see if there's any questions. So let's see. I often find that while I have an orgasm, can relieve a headache, tension, aches, and sometimes even clear my sinuses. Yeah. So your sense of smell is related to prolactin. And then there's also another melanocortin is something that happens. So let me get my brain straight. So for women, there's a couple medical options for low desire and orgasm disorder. And they're, again, female sexuality is definitely not as researched as male sexuality. Everyone knows what erectile dysfunction is. Everyone knows what Viagra is. The treatment for female desire disorder or orgasm disorder is just not as well known. But there is a drug on the market called Valesi. It is a injectable, and you inject it 45 minutes before the sex is to take place, and it can really help with blood flow to the clitoris. And one of the things that it works with is melanocortin, which is also attached to prolactin release, which prolactin release is also attached to sense of smell. So yes, you're right. You notice that sense of smell. That's really cool that you notice that, and that's exactly true. And so using toys for prostate, yes, like those are a really good way to stimulate the prostate. There's tons of toys on the market. Penis stimulation with the prostate, I would just kind of research some different types of positions, and also like research the different types of positions, but also trust your own body and your partner's body too, right? So just like with G-spot stimulation, you kind of have to enter the vagina kind of an upward momentum. With a penis, you're going to have to kind of hit it from almost like a downward slant. And so you're going to kind of research some different positions to kind of hit it in that way. But if you're in a position that like you're going to see the headline like use this position for prostate pleasure, and then you're going to be using it, it's like, wait, this doesn't feel just right. Trust your gut and trust your body, and say like, hey, let's kind of move a little bit this way or move a little to the side, because every body is different. So let's see. Why does it seem like some vaginas are located in vastly different locations and penises also like that as well? Okay, so when we look at genital formulation or formation in utero, right? I feel like I'm about to nerd out for a second, but I'll try to keep it short. So when you have a fetus, like the first maybe like 12 to 13 weeks, all of the parts are there. Everyone starts with the same parts. And so when we start to get up into like the 12 to 20 weeks, that's when the sex starts to differentiate. And so it kind of starts moving around and organizing in different ways. So the clitoris structure is the exact same structure as the penis structure. It's just organized different. The same way with, like the ovaries are the same as testes. They're just in different locations. And so that's a very complicated process to take this kind of default, cell, these default cells and where they're located and moving them all around to different locations. And so sometimes it just looks different, it's genetic. Sometimes it, maybe puts the urethra a little bit closer to the clitoris. Sometimes, you have more intersex genitalia. And so, there's just all sorts of ways that can be organized genitally, through chromosomes, through hormones. When we start looking at intersex people, there is a vast number of intersex people that are in kind of all different types of intersex, whether it is chromosomal, hormonal, or genital. And there are as many intersex people in the world as redheads. So think about that. We see redheads, we all know redheads, right? Like they're everywhere. And there are just as many intersex people as redheads. That's the prevalence. And some people who are intersex don't even know that they're intersex. And so like kind of when we're talking about genitalia, it can be different. It can look all sorts of ways. And all of those ways are natural. All of them are normal. And as long as it is not causing distress to the owner, they're perfect just the way they are. Are there any more questions? I think we might have one more coming in. Let's see. So if you do have any other questions, you can definitely reach out to me here, and I'm going to go onto the class right now and get a space. If you have any comments or questions, you can put them there and I can answer them later. But yeah, all right, well, I will see all of you folks later. Thank you for joining, and I hope you have a great evening. Bye.